So, time is now 3 o'clock, and I think we could start. It is mine and Karin's great pleasure to introduce a session on DCCC-RT. This session will be, the talks today will be focused on recurrence patterns after radiotherapy. We've asked Ruta to go through some of the methods that is out there. She will focus on methods used in head and neck, but I hope that will at least give an introduction to some of the methods that are used for recurrence pattern mapping. And then we'll have Dr. Schmidt from Wien talking on cervix cancer recurrences, and then at the end we have Anouk, and Anouk is a little bit late, but she will be here. She will talk on glioblastoma's recurrence pattern. But first up is Dr. Sukauskaite from Odense University Hospital. She will give a talk on head and neck recurrence pattern, which has been her specialty both through her PhD and now through her postdoc. So Ruta, please go ahead. Oh, so sorry, the talks, we will catch up with the questions afterwards because it's a live online show. It's a little bit difficult getting interrupted. So we will catch up on questions between each talk and then have a discussion at the end. So, Ruta?
Yes, thank you so much for this opportunity to talk to you. I will try to share my my screen now. And I think it's there now. Can you see it? And can you hear me too, I suppose?
We can see the talk in develop mode, not in presentation mode.
Are you sure?
Yes, at least that's what I'm seeing.
Okay, but it's in presentations mode, and you cannot see that I'm changing slides?
No.
Okay. This one.
We tested this prior, yeah. And now it's fine.
Okay, perfect. So yes, I would like to talk about the recurrence patterns, mainly, of course, about local regional recurrence pattern in head and neck region, but also about some methods to analyze generally recurrence patterns when we have some imaging modalities. So firstly, about treatment failures in head and neck region, we have there some Venn diagrams. On the left, we have a quite big amount of patients from the HANCA database that were treated between 2000 and 2012 using both surgery and radiotherapy. And you can see that despite a potential to be cured because this disease has a local regional onset, there is quite an amount of patients that recur either locally or regionally or both. In this Venn diagram on your right, there is my data that I looked at only patients who were treated with IMT technique between 2006 and 2012 in 3 treatment centers in Denmark, and you also see that the result is the same. The majority of failures occurs in T or N side. In this slide, there is more information before we go further, because treatment failure is very important to represent local tumor control, but it actually consists of both tumor persistence and real tumor recurrences. So the persistences we cannot analyze using image modalities because it's on itself already some kind of treatment failure. So both my research and other researches that I will present here will consist mainly of real recurrences when we have treated patient and they don't have disease that occurs somewhere afterwards in follow-up. Another thing that has to be clarified, that different researchers, different publications look at different values of 3 or 5 years local controls. And in our research, we also decided to be consistent and follow our colleagues from Odense head and neck surgery department, and stated that we are more sure to call local regional failure when it occurred in the same anatomical subsite or close to it, and in the first 3 years after completed treatment. And of course, if there is a oropharyngeal carcinoma, so it's the same P16 status. So it's a short introduction that we have a issue that we have local regional recurrences after curative treated patients. So now some slides of registration of scans that we have in our hands. When we talk nowadays, so it's mainly CT, MRI, or PET scans we can play with, but actually not so long ago we had only 2D radiotherapy techniques where we used X-ray images, and the clinical evaluation of primary tumors was crucial because these drawings were afterwards transferred and the treatment was based on bone anatomy only. So when more than 20 years after primary treatment, this patient had gained new primary cancer in the same region. So the only thing that we can compare there is looking side to side and say that, okay, this patient had received a curative treatment at the same region, nothing more, nothing less. But to perform analysis using planning CT and recurrence CT, images have to be registered, or in other words, a geometrical transformation that best aligns 2 sets of images has to be performed. This is a process that has many steps, many parameters and metrics are used. But in our everyday, the main things that come out of it is our using a rigid registration between 2 image sets where only 3 rotations and 3 translations are allowed. So this is very primitive, we can say, and that could be done okay when we have very few anatomical differences between image sets and this very localized region we want to perform registration on. But more appealing is deformable image registration, where each voxel can have its own transformation due to millions of parameters used. The final output usually of all the deformable image registration algorithm is a deformation field that correlates each point on the 2 image sets. So this registration is more appealing due to its flexibility. But on the other hand, the large number of degrees of freedom in this process can actually result in unrealistic deformation. So it's preferably that deformable registration algorithms are validated before a specific use of them. So this was a technical part of image registration. When we had performed that, so there has to be some approaches how we analyze the recurrences, and the most basic approach is volumetric approach. When we have a treatment volume that is in orange there, and we have a recurrence volume, and we simply analyze the overlap of these 2 volumes. Since volumetric approach is one of the first, so mainly rigid registration is performed. So there are few results that were published in the beginning of 2000. Both of them is from USA. There are 58 patients that received either 3D conformal or IMT treatment. And the recurrences were grouped simply in field if more than 95% of recurrence volume was within the 95% of isodose. Marginal recurrences could be spread if 20 to 95% of their recurrence volume was within 95% of isodose, as it's seen in this picture there. And the outfield recurrences had less than 20% of their volume inside the 95% isodose. And in this example, out of 16 recurrences, the majority was in field. Chow all in 2003 also looked similarly at IMT treated patients, and the finding was the same. The majority of recurrences is in field, but already here Chow began to discuss that IMT treatment cannot be just looked so simple as more simple radiotherapy techniques. So we come to some cautions using this volumetric approach, because it appeared from pre-IMT era where recurrences could be evaluated only in relation to the treatment field and the dose within that field. But that does not apply to nowadays radiotherapy techniques. Firstly, the high dose conform the target very close. So in principle, one should expect more marginal recurrences using volumetric approach. And secondly, the dose intensities vary also inside each simple beam. So this also would make volumetric analysis misleading. And this is one example that Christian made to my PhD, illustrating simply that the last 10 to 15 years had also evolved in treatment techniques, with conformity improving using only few treatment fields or using automatic generated plans, and the unnecessarily irradiated volume also is decreased. So therefore, the volumetric approach is not so good anymore. And the third thing actually also is that the influence of tumor growth and time to diagnosis can also mislead using volumetric approach, because as it's known, many patients who had recurrence in head and neck region, they can go without any symptoms in sometimes. So when the imaging modalities is performed, maybe then it's already outgrown the primary tumor volume. So it would be nice to find another more precise method to analyze the recurrences. And already more than 10 years ago, it was stated that recurrent tumors after radiotherapy, they originate from at least one surviving cancer stem cell that are radio-resistant. So therefore, it is introduced a focal approach to analyze recurrences by estimating a possible point of recurrence origin. Theoretically, this method is both less time to recognition dependent and better represents the assumption that cancer recurs from very small volume. Besides, a more precise approximation can be also made of what exact dose was given in this particular point. Using focal approach, it can be either used mathematically estimated point of origin or observer identified. Both approaches are possible. Mathematically estimated are more reproducible, but observer identified can incorporate the knowledge of anatomy and disease spread. So there will come some research on that. In 2013, colleagues from Netherlands, they began to look at this using this approach, identifying a center of mass of the recurrence and measuring the shortest distance to the treatment volume boundary. And they tried also to look at a volumetric approach and compare these two approaches. So in the table here, in the left side, there is results of volumetric approach to look at these recurrences, and in the right, there is a center of mass approach. It is seen there that the majority of recurrences actually using volumetric scheme are in GTV as marginal, but become in CTV afterwards as infield recurrences. But using point of origin scheme, the majority local recurrences are stated as infield. Regional recurrences had quite some different recurrence pattern, but also the point of origin method shows that almost all of them, except of some outfield failures, are infield failures. And looking in the left graph here, so overlap ratios in volumetrically marginal recurrences can reach between 94 and 30% respectively. So short message from there, that using point of recurrence origin, most recurrences are infield, whereas using volumetric schemes, they can also still be marginal recurrences. Another publication from Portugal was performed using the same approach, and the recurrences here in the figures represent the center of mass, and the numbers above represents the results of using volumetric approach with treatment volume. So again, the majority of recurrences are in the gross tumor volume or in the tumor bed, and there are some regional recurrences that also appears mainly in field. Furthermore, some further improvements are also made, and there is publication of Mohammed et al. That with their proposition that recurrence using center of mass could be classified in relation to both treatment volume, but also what dose was given to that. So I will not go further into that, but as you see, there is going some improvement to classify more and more specifically recurrences using the center of mass methodology. But many of you know that the center of mass represent the ideal scenario, that the tumor cells, they just grow isotropic from this center of mass. But in head and neck, it's not a case. In many cases, we have air cavities, we have bony structures, so the cancer cells, they can find another path to grow. And therefore, there has to be also looked more specific on the tumor and recurrence spread. So we have colleagues, and I could see that Ivan was among you today. So more than, in 2010, they begin to look already at the recurrences at PET-CT scans that were used in planning and recurrences afterwards. And in the beginning, they also looked at both volumetric approaches, but also identified another measurement, a mathematical point of origin on NIDUS, that defined a point that has a longest, shortest distance to the recurrence volume. In general, the volume overlap methods assign the recurrences to more peripheral target volumes compared with focal methods, and it's not always right, especially when we talk about also looking at SUV value. So in 2014, they published the largest study concerning this methodology. Among 520 treated patients, there was found 100 patients with recurrences, and in 39 patients, there was obtained imaging for these recurrence. There was calculated the recurrence density when the total number of recurrence in a volume divided by the summed volume of all the corresponding target volumes for all 39 patients. And this is a presentation of treatment volumes. The areas of circles are proportional to the average physical volume of corresponding high dose, intermediate, and elective dose volumes treated. So in general, 96% of all recurrences occurred inside the region that received the highest prescribed dose. More than half of them were inside of FDG GTV volume that had also the highest recurrence density as calculated. And furthermore, the density also correlated significantly with the percentage of SUV marks. So the main conclusion of this big study was that there is no to be afraid of marginal misses using IMT techniques. The only one recurrence was outside the treatment volumes. All the other recurrences are inside the high dose volumes. One of the newest and most one of the newest publications that actually is maybe not yet published or has to be published soon. It's on also sinonasal cancers in Denmark. And the colleagues from Aarhus looked also at the recurrence pattern of 184 treated patients that had 39 recurrences with imaging. And in this waterfall graph, you can see that majority, 74% of recurrences also in sinonasal cancers that were curative retreat occur inside the CTV volume. So talking about head and neck cancer and to curate these patients, there is always a balance. We want to give a high dose to eliminate cancer, but we have to be very aware of the local side effects that high dose or high treatment volume can result in. So the question, what is enough can be made there, but in the first radiotherapy guidelines that encompassed also IMT treatment in Denmark, it was actually difference of what volume has to be was used to these curative doses in Denmark. Some centers used a GTV to high dose CTV margin of about 5 millimeters. Other centers 0 millimeters, and some centers East Denmark used 10 millimeters or even more. So first of all, back in 2014-15, we wanted to look if this could make a difference in local recurrence pattern. If the centers use different margin, how can that be showed in the outcomes? So we looked at almost 1,600 patients that had squamous cell carcinomas in larynx, pharynx, and oral cavity, and were treated with IMT-based radiotherapy between 2006 and 2012 in 3 centers. In general, radiotherapy dose and addition of chemotherapy and nimorozole were according to the DHANCA guidelines at that time. So it's the most typical treatment group for head and neck cancer patients. So out of these patients, we found that 272 had local failures, but persistent tumors were excluded. So we ended up to analyze 119 patients that had CT verified local recurrences and where deformable image registration could be performed. So the GTV to CTV margins were plotted for all centers. And you can see on the x-axis that it's actually some dispersion in these margins. And we divided after the predominant geometrical margins in two groups, small group and larger group, more than 2.5 millimeters, and the smaller patient group that we analyzed had an anatomical margin. It was mostly either oral cavity cancers or laryngeal cancers. When we looked at local recurrences in these three margin groups, here in the x-axis, you can see the mean distance from the point of origin to the GTV. So from 0 to left, it represents that the recurrences are inside the GTV. And the red color here shows that the majority of the recurrences were actually covered by 95% isodose curve. So there was no difference of the spread of recurrences generally in these three margin groups. So univariate analysis here for all these three centers and 3-year local tumor control did not show any difference if we look at patients who were treated with accelerated IMT radiotherapy regime, meaning with 6 fractions per week. But of course, there are another disease-related and treatment-related factors that accounted for recurrences, but not centers per se. So some years later, from 2013, the Hanke treatment centers agreed to be more conform and to use a more homogeneous or margin in all the Hanke treatment centers. So it was agreed on 5 millimeters margin that we also follow now, and that is also internationally adapted now. So now we wanted to see, we have old guidelines and we have newer guidelines. Was the local control improved or changed in if we look at the patients treated 3 years using old Hanke guidelines and 3 years using new Hanke guidelines? First of all, in this graph, you can see the big issue. So in using old guidelines, the margins from GTV to CTV are again very dispersed, and the median GTV to CTV margin in this period was 9.2 millimeters, whereas using new guidelines, the margins were much more concentrated, around 5 millimeters, and the median margin here is 4.9 millimeters. And looking at these 3 same centers that we have data from, using the old guidelines between 2010 and 2012, and using new guidelines between 2013 and 15, the volumes of CTV had been more consistent and more homogeneous between these 3 centers. So we have data now of about 1,700 patients, again from these 3 national Danish centers. 788 patients received treatment using old guidelines and more than 800 using new guidelines. We did not include oral cancers in this part because it accounted only for 6% from my PhD data. So we look at the main cancer sites at this time. And again, treatment was definitive IMT treatment plus minus chemotherapy and radiosensitized according to the Hanke's guidelines.
Uta?
So in this
Uta, you are almost at half an hour.
Oh, Jesus Christ. Okay, so it's almost finished. So now we could see that the local control actually improved using the new and more homogeneous Hanke guidelines. And actually it is also the same disease and treatment related factors that relates to more failures, but no difference between 3 centers or no difference between guidelines influence the recurrence pattern. So the conclusion of Maivi's talk that it has to be image registration performed to further analyze the recurrence profile. Focal approach is more useful in the nowadays treatment techniques. And in general, local CT-verified recurrences tend to appear in high-dose treatment areas despite their different margins, and mainly are influenced by disease and treatment characteristics, not nothing else. So that was all from me.
Oh, thank you, Ruta.
Yes.
A little long compared to the fact that we asked for 20 minutes, but okay.
Okay.
We have 30 minutes per talk, so a single question here, perhaps. So Kenneth, maybe you will ask the question of Kenneth posted a question on the chat. Why the definition of persistence and recurrences has to be like this, and you somewhat answered the question, but then why not include persistent in the focal approach?
Yeah, because you cannot, because it always has been there. So the disease was not gone, so you cannot. You cannot analyze from point that when we use point of origin method, so it has to be something new to look at, not something that was always all the time.
Maybe Kenneth wants to elaborate.
Yeah, it's the definition. It's within the GTV, the recurrent disease. Can you hear me, Ruta? Yeah, the definition is within GTV. If you group them together with all the other recurrent diseases within the GTV, that might influence. If you try to make some kind of TCP model or another kind of quantitative analysis of your recurrences.
So the at least the analysis of the local control included the persistent tumors in Ruta's both so in that fact at least the persistence are taken into account, but the focal approach has not been used for the persistent tumor due to the fact it's assumed that it's inside of the GTV, which is presumably also correct. Okay, I think we need, in the interest of time, we need to move on. Kai has a guest from the big country of Austria. Yeah.
Yeah, thank you, Christian. And maybe we can also just motivate participants to continue to discuss in the chat if you have further questions for Ruta, so we can take advantage of having access to the chat. So in the meantime, I would like to introduce our colleague, Mark Schmidt, who is from Medical University of Vienna, a radiation oncologist. And Mark will present on recurrence patterns in cervix cancer. And what is very specific for cervix cancer is that we have a treatment where external beam is combined with brachytherapy. And in the early 2000s, an adaptive target volume was defined after response to EBRT. So it means that half of the dose to the tumor is delivered with brachytherapy and then delivered based on an adaptive target volume. So that is unique for that site, that such an adaptive target concept has been introduced so early. And it has also now been tested prospectively in the Embrace-1 trial with more than 1,400 patients having been accrued. And Max has done a very extensive analysis on the local recurrence patterns and those effects, what he will share with us today. So I'm really pleased that you could join us today, Max. So please.
Yeah, thank you very much for the introduction and also for the invitation. I think it's a big honor to be able to present data for you in Denmark. And yeah, I think it's also interesting to see the previous presentation, because I think there are quite a lot of similarities on the one hand and also quite some differences. And as you pointed out, this adaptive target volume concept on the one hand, and also the dose prescription, which is more heterogeneous, at least in the study, gives us more room to investigate more into dose finding, which is the optimal dose for cervical cancer. And I think I would like to go through this aspect. Just to repeat what Kari just pointed out, the treatment concept in cervical cancer is a combined treatment, combined EBRT plus chemotherapy, and then a brachy boost, which is equally balanced between external beam radiotherapy and brachytherapy approximately. What is important also to mention is this target volume concept, this adaptive target volume concept, which means that we take the response from external beam radiotherapy into account, and that we have in principle two major volumes. Can you see my cursor? Is it possible?
Yes.
Yes, we can see it, yeah.
So we have these two target volumes, the high-risk clinical target volume and the intermediate-risk clinical target volume. And just very simplified, the high-risk target volume corresponds more to the residual tumor after EBRT and chemotherapy, whereas the intermediate-risk volume is more related to the initial tumor extension. So what does this look like in clinical practice? So if we see this big tumor on MRI at the time of diagnosis, or stage 3B tumor, which gets then EBRT, which gets chemotherapy, and this is also very typical what we observe in majority of patients. We see substantial shrinkage of the tumor during external beam radiotherapy and chemotherapy. So this is the MRI at week 2, and then the situation at week 5. So what we see is substantial changes in the signal intensity on MRI. We see changes in the volume and changes in the shape. So if we want to go to this target volume concept again, so this is a situation which more or less corresponds what we would treat with a high dose to the high-risk clinical target volume. This is in the range of something like 85 to 90 to even 95 gray, what we would like to prescribe for this area, whereas the initial size, this would get a dose around 60 gray ideally. So, and this is the situation, what it could look like eventually. So this is the situation at diagnosis, to see this big tumor here in the cervix, in sagittal view and in transverse view. Then the patient gets EBRT and chemotherapy. We see some shrinkage, and then we perform brachytherapy almost selectively to the small, to the residual tumor. So if we now focus on the local recurrences, traditionally, we have a definition also for a local recurrence. So in this situation, we are looking at both, so persistent disease and local recurrence, so a disease recurrence after achievement of complete remission. And this means a disease recurrence or a persistent disease in the cervix, in the uterus, in the vagina, in the parametria. So this is this soft tissue which holds the uterus. The pelvic wall, of course, we have here to be careful to distinguish between also nodal recurrences, and then eventually in bladder and rectum. And of course, the major questions, what are this correlation to the target volumes of the local recurrences, and what is the correlation to the prescribed dose? And traditionally, there was this definition of a central recurrence versus a non-central recurrence. What does this mean? Central recurrence is typically located really in this is a situation at diagnosis before treatment, and the situation with the local recurrence, which really centrally inside the uterus, inside the cervix, recurs. And these recurrences are typically considered to be rather recurrences caused by radioresistance, because they are really in very, very close proximity to the applicator. And this means also receiving an extremely high dose during the treatment. So there is the assumption that these are rather related to radioresistance. On the other hand, we have these non-central recurrences, like we can see here. And here it is more assumed that this is a dose coverage problem. And here you can see an example from Vienna, from the beginnings of image-guided brachytherapy using MRI, which I think is very educational on certain aspects. And you can see this big tumor at the time of diagnosis, then the situation at the time of brachytherapy. There was a tandem ring application, and there was some optimization to push the dose more to this side, but obviously there is a substantial part not covered by the prescribed isodose. And then there is a local recurrence. I think this was 12 to 18 months later. And I think it's very interesting to see that you can link the location, so there is a spatial correlation of the local recurrence to the area also where the low dose was registered. And I think this is something of big interest, and which also then pushed towards the development of combined intracavitary interstitial applicators to improve the dose coverage and to reduce these specific local recurrences. So now we have, as Kari pointed out already, new evidence from the EMBRACE-1 study, which I think is very interesting in this direction of local recurrences and analysis of them. So what was the EMBRACE-1 study? This is was a prospective multi-center study performed at 24 international centers. It was a so-called observational study, which in this context meant that there was no fixed dose prescription for brachytherapy. However, it was mandatory that the same target volume concept, the same imaging, the same dose reporting was performed to be then to have the possibility then to make an analysis of this target volume concept, which was established in 2006. And the primary endpoint was local control, but also multiple endpoints on other disease endpoints and mobility in particular. Here you can see the description of the patient cohort. So we had more than 1,300 patients available. We see a typical distribution of the FIGO stage. So this is FIGO 2009 edition, with the majority being 2B, approximately 50%, and we have 16% 3B, and approximately 20% with the small stages with 1B patients. Approximately half of the patients were node positive, and we see the typical distribution of histology in primary cervical cancer, with the majority being squamous cell. But we also had approximately 20% adeno or adenosquamous cell carcinoma. And here you see the mean, the major treatment characteristics. So all patients got EBRT with a median dose of 45 gray. A very high percentage of patients received concomitant chemotherapy with 95%, and a little bit less than half of the patients received combined applicators. So this means intracavitary interstitial in 43% versus intracavitary alone in 57%. All patients had MRI at the time of, or almost all patients had MRI at the time of brachytherapy with applicator in place and MRI-based treatment planning. This target volume, which we are interested in, this was the median volume was 28 cubic centimeters in these patients, and the median prescribed dose was 90 gray. So it means despite being an observational and open in dose prescription, the majority of centers chose to deliver relatively high doses, which is also related to the fact that during the performance of the study, there was ongoing research also from the previous study from RetroEMBRACE, also published by Kari, showing those response relationships and the need to go for rather high doses. The median overall treatment time was 46 days. And this, I think, is the main and most important finding in the end of the study. So this is the overall outcome, disease outcome, where we can see, and I think this is already, shows that the overall concept itself works very nicely, because we observed a very high local tumor control rate in these patients with 92% at 5 years. So this itself, I think, says already a lot that the concept and also the target concept seems to be okay. But we try to look into this into more detail, of course. This is the results based on the different FIGO stages. And I think here the major message is that not only the small stages had excellent local tumor control, but also the more advanced stages, so really the big tumors reaching the pelvic wall, also had a local tumor control rate of 90% and more. So I think this is also a very important finding of the study. To go a little bit more in detail on also the question on persistent disease, I think we have a very interesting finding here in EMBRACE-1. So in total, we saw 80 patients with persistent disease at 3 months. And of those patients with persistent disease at 3 months, and I think this is a very relevant finding, 60 patients resolved at 6 to 9 months without further treatment. So there was on imaging, on clinical examination, some residual, some shrinking tumor visible, and without further treatment, these tumors disappeared, which is, I think, a very relevant finding if you discuss the possibility of salvage hysterectomy, which obviously is not necessary in the majority of patients. So this means that we had 20 true persistent disease, so 60 resolved, leaving 20 which really had true persistent disease with further disease progression, which sums up to a 98% complete remission rate. In addition, we observed 78 local recurrences after complete remission with a follow-up of 51 months. Also very important is that the majority, so 73% of these local failures occurred within a very short time, within 24 months after treatment. So this sums up a total number of local failures of 98 in total. Of those, 48% had synchronous nodal or distant recurrences. So local only recurrences were even substantially less. What is the relation of these local failures anatomically? So we could see that the uterine corpus was involved in 28% of these local failures, that the parametria were involved in 45% of the patients, the vagina in 43%, the bladder in 20%, and the rectum in 4%. So of course, more anatomical locations could be involved in one local recurrence. And what was the relation of these local failures in regard to this target volume concept we discussed before? We could observe that inside this high-risk clinical target volume, there was 50% of the local failures. Inside the intermediate risk CTV, it was 15%. And inside both, it was 24%. And not related were 11%. These were 7 cases. And it's important to mention that all of them were located in the lower vagina. And I think this is a very interesting finding because more than half of these patients didn't even have vaginal involvement at the time of diagnosis. So it is a bit questionable if we can really consider them as local failures, or at least some of them might be even new second primaries, as we know it also from HPV-related tumors in the head and neck region, for example. We also tried to look into the risk factors for local failure based on this large collective of patients, and these are the major findings of this. So the tumor size is relevant. Then we identified based on MRI imaging that the presence of tumor necrosis at the time of diagnosis is relevant for the occurrence of a local failure. Histology has a very strong impact with worse prognosis for the patients with adenocarcinoma. Presence of uterine infiltration at the time of diagnosis and at the time of brachytherapy is relevant. Rectal involvement at the time of brachytherapy is relevant. And I think very important for us to know as radiation oncologists is the second 2 points. So the overall treatment time has a significant impact, and the dose delivered to the high-risk CTV. And this is, of course, very interesting, and I think we should look into that in more detail. And based on this finding that the dose is relevant, we tried to calculate those response relationships for the high-risk clinical target volume. And since we learned that histology is such important, we tried to make it separately for the different histologies. So what you can see here are these 3 figures. You can see on the y-axis the local control probability. You have on the x-axis you have the dose delivered to the high-risk CTV. The blue curve represents the squamous cell carcinomas, the red curve, the adeno, and this is done separately for different volume groups. So for the very small volumes, less than 20 cubic centimeters, for 20 to 40 cubic centimeters, and for more than 40 cubic centimeters. And the dotted lines are the 95% confidence intervals. And I think what we can relatively easily see from these figures is that we have a big difference between the 2 histologies in terms of local tumor control and in terms of the dose effect. I think this is the one major message we can derive from these figures. And I think the second important finding is that with increasing volume, these curves get more steep. So you need obviously more dose for the larger volumes to achieve the same effect as for smaller volumes. I think these are the major findings, and I think this points already in the direction what we would like or what we could investigate in the future as the next generation of the EMBRACE studies. So at the moment, EMBRACE 2 is ongoing, and EMBRACE 2 has the same target volume concept and a uniform, so not an open dose prescription for brachytherapy, but a fixed dose prescription. So they should receive a certain dose, which is in the range of 90 gray to the high-risk clinical target volume. And I think if we look at these graphs now, I think we can see that there could be the possibility to go one step ahead of this, to go towards risk-adapted dose prescription. And I think this is what I would like to illustrate here. So if we look more in detail on this small volume, so less than 20 cubic centimeters, and look at the blue curve here, this is already very, very flat. So we don't see a big difference whether we deliver 80 gray or if we deliver 90 gray. So we could question whether there is some room for dose de-escalation for the small squamous cell carcinomas, maybe taking into account also the molecular profile in these patients. But this is something which we are looking forward to investigate within the hopefully upcoming EMBRACE-3 study in the future. On the other hand, if we look at the larger volumes, we see that in particular for the adenocarcinoma, but also for the squamous, we are in the steeper part of the curve. So we obviously need high doses for these larger tumors. And I think this is the idea overall, to have risk-adapted dose based on histology, based on volumes, and then also taking into account external beam radiotherapy for the nodal approach, but this goes a little bit beyond the presentation for today. So to conclude, I think what is the most important finding what we give with EMBRACE-1 is that we see a very high local tumor control rate, and that this adaptive target concept using MRI for contouring, using MRI for treatment planning is feasible in a multi-center setting. I think this is already a very important finding. And secondly, that this adaptive target concept based on our findings, based on the relations of the targets of the recurrences, seems valid. We could establish now risk factors for local recurrences, and also establish dose response relationships for local tumor control. And I think last but not least is the endpoint itself, local tumor control, a relevant endpoint, because in particular in cervical cancer, you could question, well, you can do salvage hysterectomy and then the tumor is gone. This is the overall survival in the EMBRACE-1 patients, in this 98 patients with local failure after the local failure. So the median survival in this cohort is unfortunately very, very poor. This is 10 months. So this, I think, even more points out that we need to optimize our treatment to reduce this number of local failures as much as possible. Thank you very much for the attention.
Thank you so much, Max, for a very comprehensive presentation. So we have time for questions. While you raise your hands, I just want to put forward a question by Trine Nøtrup, who is asking about the persistent disease, if this is verified with biopsy.
Oh, sorry, this is the wrong thing. I just wanted to open the slide again. Give me a second. I'm not sure if this works out now. Yeah, here it is. No, it is not verified by biopsy in all patients. So we tried to ask for biopsies as much as possible, but this was not the case in all patients. In particular, those who had this so-called slow response, of course, there is a group of patients where a biopsy would be very interesting to see. But in the end, we know also from the salvage hysterectomy series that these patients sometimes have residual tumor cells where it's questionable if they would have gone away without any further treatment as such also. Imaging is mainly MRI in these local recurrences in the persistent disease. Biopsy is not always present.
Yeah, thanks, Max. Was there a hand from Ivan with a question?
Otherwise, I have a question, Max. So you're talking about potentially de-escalating the small volume squamous cell carcinomas, but the benefit there would be lower toxicity, I presume. But is there a close relationship between the toxicity seen and the dose prescription that you give?
Yeah, thank you for the question. So yeah, I mean, it's just the way you answered it already yourself. The idea of dose de-escalation is reduction of mobility. And we should not forget that even in the small tumors, we see substantial mobility. And we see also, we have, maybe Kari can contribute to this even more. We did already simulations on the impact of dose de-escalation, what we could eventually reduce in morbidity. But we should not forget, for the overall cohort of patients treated in EMBRACE-1, despite having this MRI-based approach, this adaptive target volume approach, we see substantial morbidity in a large portion of patients, which seems to be less than it was previously without MRI, but still there is substantial morbidity. And the idea, the hope for dose de-escalation is that there is a reduction. And I think this is quite, this hypothesis is hopefully quite plausible, because we see that increasing dose for the organs, both for bladder, for rectum, for bowel, increases morbidity. So we have established also dose response or dose effect relationships for the organs. And so I think the assumption to reduce the dose will lead to reduced morbidity is hopefully true.
Thank you.
Kari, do you want to add something for that?
I think you explained very comprehensively that we have because we have all this data, we have now very solid evidence of the risk factors and the dosimetric risk factors. So we can pretty well from NTCP models predict how much of morbidity reduction we expect. So yeah, so we believe that there is a clinically relevant reduction of morbidity with these kinds of de-escalations that we are considering. We are also considering a de-escalation of the nodal dose, which is also something with these big pelvic fields that the elective dose, even if that is just 45 gray at the moment, is also carrying a lot of toxicity. Maybe I can also, it's also a bit of a comment and also a bit of a relation to the presentation by Ruta. Because what you showed, Max, is that these high-risk CTVs, they are in median around 30 cubic centimeters and often much less. And if we compare that with the initial GTV, we are irradiating very tightly with that brachytherapy. So we are actually irradiating volumes which are smaller than the initial GTV. So that brings me back to a question to the head and neck. Because what I understood, what you saw from the data from Odense, irradiating GTV with a tight margin went pretty well. And then you still went for a margin in the national guidelines, as I understood, of 5 millimeters between GTV and high-risk CTV, maybe also as a compromise between Copenhagen and Aarhus. I don't know what were the negotiations, but I think it looks very attractive to irradiate tighter, and well, for cervix cancer that obviously works really well. We have this local control more than 90% in these very advanced tumors. So what are the thoughts about that from head and neck side of further decreasing margins?
Yeah, we will look. We are not finished to look at the data, and the toxicity is not a big issue here anymore. So that is very promising, because also it is about accelerated treatment. Talking, it is nowadays. So we are moving closer to that. But also these 5 millimeters is mostly a compromise, but also made internationally, because all these surgery specimens, they show that it is all about the first millimeters, not even 5 millimeters, that recurrences occur in these small studies that we have mostly in oral cavity. So this is a compromise. Yes, with 5 millimeters, but yeah, maybe we are more brave one day and go further. That yes, the 0 millimeter and much higher dose, maybe then that is the way to go.
Maybe Jørgen has a comment.
Yes, 2 points. Kai, you're right, it was a compromise as noted by Ruta. But the origin of the zero margins in GTV in the HANCA was from the extension from all two-field treatment until IMRT. So we have previously just put 5 millimeters and 5 millimeters for any setup errors and machine uncertainties. So in the old time, from the first HANCA trials from the 90s, the actual margin at the first fraction of treatment was 0 millimeters. That was what was taken into IMRT until people started to evolve IMRT in their own way, and then we went back to a compromise. But it's my impression that about 30% of our tumors are very, very radio resistant, and you might give 100 gray without local control. So my impression is that the HANCA should go further with introducing zero margins from GTV to CTV.
Yeah, and it should be remembered that the HANCA analysis is first of all retrospective in different centers, and also the guidelines were written up before the analysis of Ruta's project. So now we have some indicia showing us that it could be potential safe to go to 0 millimeter, but I would also like to try and use some of that dose toxicity reduction to increase the dose for some of those tumors. But perhaps like you in the pelvic area, look at if we can use that more cleverly for some patient, avoid increasing it for every patient. Okay, I think Max made sure that we are on time again, which is really good. So next talk is on glioblastomas. Anouk from Aarhus University Hospital is working on glioblastoma and recurrence pattern there. So Anouk, please, we are very interested in your talk.
Yeah. Yeah. I think you can see my screen now.
Yes. Perfect.
And now presentation mode?
Yes.
Good. Yeah. So thank you, Christian, for the opportunity to present our work here today. So I will talk about recurrence patterns in glioblastoma, and so I guess some similarities to the other sites, but I think in general we're not nearly there yet, as you are in your projects. So it will be mostly about the knowledge that we want to generate and what we want to do, but it's all still very much ongoing. So we have a national project, and our aim is to establish a cohort of more than 1,000 patients with radiologically documented recurrence. And so we're still in the data collection phase, and I will only show some preliminary results of a small part of the intended cohort. But ultimately, we would like to use this recurrent cohort to optimize the radiation target and to develop a patient selection tool for high dose radiation. So first, a short introduction to glioblastoma and the standard of care. So can you also see my mouse?
No, not so much.
Okay, I will take this one.
You can write, yes, perfect.
Yeah, okay. So glioblastoma is the most aggressive form of primary brain cancer, and an MRI scan, it looks like this, so a contrast enhancing abnormality. And when we have suspicion of glioblastoma, patients proceed to surgery. And then when we have pathological confirmation of the diagnosis, patients proceed to chemoradiotherapy. So this is 60 gray in 2 gray fractions with an overall treatment time of 6 weeks. And then after this, patients finish with adjuvant chemotherapy. And after this intensive trimodality treatment, glioblastoma always progresses. So here, yeah, we see the primary lesion. Then after surgery, we have a surgical cavity and everything seems removed. And then after treatment with chemoradiation chemotherapy, we see that it's growing again here in the contrast enhancing abnormality. And after that, it's growing even further. So it's glioblastoma always progresses, and it progresses in the brain itself. So it's very rare that it progresses outside the brain. So the overall treatment goal is therefore to control the tumor for as long as possible and thereby relieve the patient from symptoms from the tumor and improve quality of life. So historically, if we go into more detail about the radiation treatment, patients were treated with whole brain radiation, which we can see here on the right, on the left, and then on the right we see survival curves for different doses with whole brain. So the top one is for 60 gray whole brain radiation, and then 55, 50, and no irradiation. So there's a clear need for high dose, but also a need to spare neurotoxicity. So the treatment has evolved to partial brain irradiation in the 80s and 90s, as shown here. And this is very old, but I'm mentioning this data because the target for partial brain irradiation at that time was based on recurrence patterns, and it's basically still the same as what we use today. So we go to the target. So glioblastoma is considered mainly a local problem with a high risk of tumor infiltration in the near surrounding. And that's based on those recurrence patterns with CT data and autopsy studies. So the GTV is then the contrast, this based on the surgical cavity and any residual contrast enhancement that's left after surgery. So to cover microscopic disease, we take an isotropic 2 centimeter margin from the GTV to the CTV, and then 2 or 3 millimeter PTV is added. So here we can see that on MRI, that isotropic margin to the CTV. We can also see that it's edited here for anatomical barriers. But nowadays, we make an MRI for radiation treatment planning. We use more conformal techniques. We've added chemotherapy, etc. So we've re-evaluated this target definition in patients treated in the way we do now. And I will show those results, but first I will explain a little bit about the methodology in glioblastoma. So here we have again the treatment pathway where we have the treatment scanning before and after surgery and the one that's made for to plan the radiation. So preferably we take this one as a reference scan. And then about 3 months after the last irradiation, after the end of radiation, the follow-up scanning starts. So at that time, patients can already have had some chemotherapy, but we do 3 monthly MRI scans. And then we have a standardized procedure to identify the scan of first progression according to Urano criteria. And we take that to assess the recurrence patterns. So we relate the recurrence scan to the reference scan. But there are a lot of ways to do that. And this is just from a review showing all these different ways for all kinds of methodology and definitions. Let's go to the most commonly used. And that's the volumetric approach, which was already pointed out by Ruta today. But then we have a little bit different cutoffs than in head and neck. So here we have the schematic target again with the 95 isodose line in black. And then the yellow star is the recurrence. And it's classified as central if more than 95% of the recurrence volume is within the 95 isodose line. And then as infield, if 80 to 95% of the recurrence volume is within that isodose line, marginal is 20 to 80%, and distant is less than 20%. So it could be that these distant lesions are touching the 95 isodose line, or for example, that they are in the contralateral brain. And we have to assess this type of method as a whole. So we have to look at all the entire recurrence pattern together. So this is the overall picture of what we see after the treatment that we give today. And these are results from the three largest series describing this. So around 75% of the recurrences are central/infield. These are usually reported together. Then 10% marginal and 15% recurrence are distant. So we're now learning more and more that glioblastoma is not just one disease, and that there are clear prognostic factors, and that these factors may also influence the recurrence pattern, and perhaps are that those patients with marginal and distant recurrences. So there's a little bit of evidence on these clinical parameters and that they might influence the recurrence pattern. So here I've placed all these 3 classifications on top of each other. So for the total patient population, and then next to it, this subgroup based on patient tumor and treatment characteristics, where we see an in-field central recurrence percentage of only 40%, and thus way more marginal and distant recurrences. So, but these are just small numbers, and we're still using, didn't change anything in the clinic, so we're still using the same target definition for all glioblastoma patients. So we move on to optimizing the radiation target. So we have this suggestion that there are tumor misses, and especially in certain subgroups. So we question whether the current target is good enough. And besides these tumor misses, we also see that this 2 centimeter expansion leads to large volumes. So often in the clinic, we have to reduce it to 1 or 1.5 centimeter to keep dose constraints for the normal tissues. And then I'm showing this recurrence again here to show, to illustrate that there's preferred tumor growth along the white matter tracts. So these recurrences are not growing isotropically, as was also mentioned today already. So overall, we think we are overshooting with a 2 centimeter isotropic margin, while we're missing tumor extensions in certain directions. And we would thus like to make this CTV more precise for covering microscopic disease. But how can we use the current information to adapt the CTV? So here I've drawn 3 examples of recurrences that would all be classified as central or in-field. And then if we would just do a margin reduction to, for example, 1 centimeter, I think that would be okay in this situation, but not in these situations. So there are advantages to the volumetric approach in assessing the recurrence patterns, but there are also clear disadvantages. So we have a problem with this approach. So in our national project, we are set out to take into account each recurrence lesion separately instead of generating 1 recurrence volume. And we want to investigate first how many recurrence lesions are there. Are they continuous with the GTV or not? What's the direction, and what's the distance with respect to the GTV? And then we want to investigate what are influencing factors, what patient tumor treatment factors in a multivariate analysis are changing the location of the recurrences. So that's all pretty basic and nothing really fancy, but it's all so really unknown so far. So I have some preliminary results from our small cohort of 171 patients with radiologic progression. And we see that about a quarter of the patients had more than 1 lesion at first progression. And a fairly similar percentage was reported by a group of Heidelberg. And then we additionally saw that most patients actually had 2 lesions from the ones in blue, but it could range up to 9 lesions. So these multiple lesions at progressions is a frequent event, and we should take it into account. So then we scored whether these recurrence lesions are continuous or not with the GTV. So this one we would score as continuous. Here it's not continuous, the GTV is at another location, and here it's combined. So here's the surgical cavity with a recurrence, but there are also separate lesions that are not continuous with the GTV. And I guess not surprisingly, but we've scored local only disease in 64% of the recurrences, and then non-local and combined in close to 20%. And this was also, this non-local percentage was also reported in one other paper. But overall, this information will help us to understand which patients have local disease that's confined to the initial location, and which patients have more spreading disease. We think that these patients could benefit maybe from a smaller CTV, but these can benefit from a differently placed, probably asymmetrical CTV. So this is all descriptive work, and we're learning a lot, but we are still not adapting anything. And to actually optimize the CTV, we also need to know the direction and the distance. So we are planning to develop a 3D artificial intelligence prediction model for this, where we give input to the algorithm, which will contain patient parameters, tumor parameters, treatment parameters, together with imaging data on the primary tumor location and also on the recurrence location. And then our algorithm will learn what happens with what baseline situation and can predict for a new patient in 3D, again, a recurrence probability map. So this is then would serve as a surrogate for microscopic disease at start of radiotherapy. And when we have done all this future work, we will have to think about how to best translate such a recurrence probability map into a new CTV definition. So I want to move on to the patient selection tool. So current results from radiation dose escalation above 60 Gray have not been convincing yet, but one reason for this could be the lack of patient selection. So we actually hypothesized that it's these patients where the tumor burden is local and it's confined to local and it stays local, can potentially benefit most from high dose radiation. So as mentioned before, this in-field failure suggests that we don't give enough dose, right? We don't think that these patients can benefit that much because these already obtained local control with 60 Gray and need a different strategy, maybe better salvage treatment, etc. And these patients also have a local problem, but if we would deal with that, then this other problem is still there. So overall, they may not benefit from better local control because the tumor is too much spread out. So we are interested in developing a patient selection tool to identify these patients up front, so where the tumor stays local. And our preliminary multivariate analysis showed that both MGMT status, so a genetic biomarker, and the extent of surgery, so how much the surgeon could remove from the contrast enhancing part of the tumor, was associated with the type of progression. But overall, these are descriptive results only, but overall we've seen that for each subgroup, the local only disease is still most frequently scored. So to test our idea, we also made a prediction model for type of recurrence, a logistic regression prediction model, and those results we will present at ESTRO this year. And so just to clarify, we didn't use an AI model for this, but this is something that we could also consider in the future. And then we do some assumptions in this work, and I wanted to point out a few of those. And these are preliminary assumptions for the lesions that are not continuous with the GTV. I guess those ones that are continuous, it's just more clear. So first, we assume that the radiation dose doesn't eradicate any microscopic disease, but it only slows down tumor growth, and it doesn't change the location of the microscopic disease. So we have some indications from this old literature where we had whole brain radiation and then partial brain irradiation, and then even a little bit smaller fields that didn't change anything in the recurrence patterns. So there weren't more marginal or distant recurrences. when we reduce the target. But I think we just don't know, because maybe the ways we analyzed the recurrence patterns at that time were just not sensitive enough to pick up on microscopic disease. And we also just don't have a gold standard to assess microscopic disease. So whenever we would decide on reducing the CTV, I think we have to carefully monitor it, what the effects are. So the second assumption I want to point out is that we assume that all lesions originate from the first tumor, so that they are from monoclonal origin instead of multifocal origin. And there's only very limited lab work on this, so just a few case reports. But all of this lab work is pointing towards a monoclonal origin, so strengthening our assumption here. So to summarize, we have an ongoing national project. Now we are focusing on completing our cohort of 1,000 patients with all relevant imaging data. We're focusing on automating all the data processing, the tumor segmentations. And in the meanwhile, we are also preparing an external validation set. So our first aim is to gain specific insight in the growth and the migration as seen on MRI scan. And then afterwards to develop a prediction model for recurrence location in 3D using AI. And this we then want to use to optimize the CTV. We want to use it to develop a patient selection tool for high dose radiation. So overall, it's all work towards wanting to use this retrospective recurrence pattern to identify the clinically dominant problem upfront for every patient. So I would like to acknowledge all these persons and institutions for their contribution, and especially the national collaborators, so Thomas and Trine, Rick and Christian, Aida, Bob and Slavka, at each hospital, and then especially also Jesper, Kim and Jintao for automating all imaging data handling, tumor segmentation, etc. So thank you for your attention, and I would be happy to take any questions.
Thank you, Anouk. Thank you very much for your talk. Any questions? The one question that pops into my mind is that this 2 centimeters GTV to CTV margin, doesn't that hinder doesn't it hinder us getting to know where the recurrence is if we don't look at inside GTV versus inside CTV when the margin is so big?
Yeah.
So you're looking at optimizing the CTV margin going through white matter, but with the patients we've treated, they've all, or most of them have been treated with a massive CTV margin. Won't it be very difficult to learn from that?
Well, I think we have very high local failure, right? So it's I mean, in cervical cancer, we're talking about local control of 90%, but we're talking about local failure of 90%.
Yeah.
In certain subgroups. And it's just one dose prescription, right? It's 60 gray to the CTV. So there's no dose difference between the GTV and the CTV. But I think if we want to adapt the CTV, we have to look with respect to the GTV, because this is a starting point, and then see where is it actually growing, where can we reduce the CTV, assuming that there is no microscopic growth tumor cells that we are treating with the 60 gray, and then where should we extend it?
Okay, I also have a question.
Yeah, thanks a lot, Anouk. I have a question about the next steps. So if you're successful to identify those patients who are very likely to recur locally, and then you can get a new much better target delineation, what are the perspectives? Do you want to escalate? Do you want to spare, or I mean, what is the? I'm not aware of the clinical outcome of these patients in terms of what is the window for improved quality of life, and so what is the aim?
Yeah, so this quality of life, it's really related to the tumor burden and the disease. So we see that for example, controlling the tumor leads to a better quality of life, right? And when the patient is progressing, we can actually already see it in the quality of life data that there's a decline, and it's preceding the progression that we see on the MRI scan. So it's very much linked. I think that for a group of patients, it's very safe to reduce the margin, but we want to do that in a smart way. So the only way that we can do it now in the clinic is to make that isotropic expansion from 2 centimeters to 1 centimeter, for example. And we sometimes need to do that to keep the dose constraints. So we do that for toxicity. But with the data and the things that we are learning, we want to do it in a smart way. So maybe we should reduce it, make it into an egg shape, for example, right? Instead of a sphere. So it will help us to reduce the target and save toxicity. But then on the other hand, this tumor is growing and growing, and it's causing a lot of tumor symptoms and burden. So we want to control the tumor better, and we think that one of the reasons, the ways to do that is to give a higher dose. But then we are so limited by this large volume that we have now that we usually were going for boost options. So we take the GTV or GTV plus 5 millimeter, for example, because that's the only thing that's feasible. And I think that if we really proceed this data, we could also look into a smarter boost target, for example.
Thanks.
Any questions for Anouk? If that's not the case, we can open the floor to questions for anyone, any of the speakers. It's getting late, so people are tired, I assume. If not, then Kari and I will probably end the session and thank everybody, and first of all the 3 speakers for 3 great talks, and for Louise to set up the DCCT-RT webinar as well. Thank you, everybody.
Thank you so much.
Thank you.
Thank you.
Thanks. Have a good afternoon and evening.
Bye-bye.
Bye.
Bye.